Good evening, everyone who's here and everyone who's joining after the live. Today, we come to you from Bangalore Head Neck Sciences here at Koramangala, Bangalore. And we are bringing to you the next topic in our series of webinar topics. And today, my topic is laryngeal malignancies, a little more focused towards treatment protocols. Let me go ahead and share my screen. There we go. Is my screen visible? All okay? All right. Okay, so let's get into it now. Laryngeal malignancy, the treatment protocol. Basically, it's too vast a topic predominantly because there's so many aspects to the laryngeal malignancies that are talked of in various forums in our residency and beyond. And there is a lot of different opinions of how the protocols of management should be, how the management of the disease should be handled in different type of disorders, different subtypes of the disease itself, and specifically the rehabilitation part of after the surgical management is done. So I would like to cover the whole arena of it in a very, very brief manner and go a little more into the specifics of total laryngectomy part, something that we've been doing a lot more in the recent times. So that's something that I'd like to focus on. But I would like to cover laryngeal malignancy right from the get-go of the anatomy of larynx. As always, I am Dr. Rakshita Kamath. I'm the Associate Consultant here at Bangalore Head Neck Sciences, and I'm a part of the Bangalore ENT Institute. So, introduction to larynx. Just to refresh our memory about exactly what and where the larynx falls into. So it's basically in the anterior midline of the neck, extends from the epiglottis to the cricoid cartilage. This is the diagram that all of us have been taught in detail during our residency. For all my junior colleagues out there, stands between the C3 and C6 vertebra in males, and more often in females between C1 and C4. And again, there's length difference. It's longer in men with a bigger transverse and a bigger AP diameter, and the internal diameter up to the age of 3 years is 3 millimeters, with the adults being 12 millimeters. This is an overview of the overall framework of the larynx, and the hyoid, the membranes, again, the thyroid cartilage, the cricoid cartilage, rings of the trachea, as a cross-sectional sagittal view of the larynx when you look at it laterally. And again, another image which gives in great detail the different ligaments and the different attachments that we have, specifically attachments like the conus elasticus, the cricotracheal ligament, again, the different parts of the thyroid, retinoid, and vocalis muscles. The angle specifically is focused here where they talk about the male angle being 90 and females being 120 degrees. And again, the overall cavity of the larynx per se is from the inlet of the larynx to the lower border of the cricoid cartilage, and it is placed very obliquely, as we know, with the boundaries anteriorly being the epiglottis, posteriorly being the inter-arytenoid folds, and on the either side being aryepiglottic folds. Again, there are different mucosal folds within, but overall the entire site of the larynx is subdivided into the supraglottis, the glottis, and the subglottis, where here the image shows the different parts of the particular larynx divisions. The subside specifically in the supraglottis. Now, suprahyoid epiglottis part, there is the infrahyoid epiglottis part, the aryepiglottic folds in the laryngeal aspect of it, and the arytenoids. Now, also the glottis again is subdivided to the true vocal cords, including the anterior and posterior commissure, with the subglottis being a single subunit. Now, again, just to go into a little bit detail about these subsides, because they're very important to understand when we talk about the cancers of the larynx. The supraglottis connects from the base of the tongue to the larynx, and the subdivisions, like I said, was the epiglottis, the suprahyoid, and the infrahyoid part, with the again the aryepiglottic folds and the arytenoids. Specifically, the marginal zone is where the pyriform sinus and the postcricoid area malignancies arise from. And More importantly, here we have to remember that anteriorly, the pores of the epiglottis is what connects it to the preepiglottic space, and involvement of preepiglottic space changes the staging of the disease. That's something that I'll be talking about later. Again, in the further arenas, there is the false cord, which is the thin shelf-like partition above the ventricles, with the ventricle being the lower limit of the supraglottis area. There is the saccule of the ventricle, which extends between the vestibular ligament and the thyroid cartilage, and submucosally it goes into the paraglottic space, the medial wall of the piriform sinus, and the preepiglottic space. Vertically downwards, the spread can then be from the ventricle to the vocal cords, and this spread is what we call the transglottic carcinoma. The lining of this particular area is usually the ciliated columnar epithelium, and there is very, very, very rich lymphatics. Now, this is something that we have to focus on here, and the exit is through the thyrohyoid membrane to the jugulodigastric nodes, with bilateral cervical mets being very, very common in supraglottic carcinomas. Now, in the glottic area, when we talk about, again, this diagram gives a very brief overview, a line overview of how the glottis looks like. It comprises of the main vocal cords, that's the true vocal cords, with the anterior and posterior commissure, and then something called the rima glottis, again, the space between these cords, with the anterior two-third membranous cords, the free border, the horizontal spread becomes more common, whereas in the posterior one-third being more fibrous, it shows less horizontal spread of carcinomas. And these areas are all lined by non-keratinized stratified squamous epithelium in their normal region. Again, there's a beautiful diagram that I got from the textbook Functional Histoanatomy of the Human Larynx, which talks about the anterior glottis and the posterior glottis. The superior spread usually is limited by the ventricles, and the inferior spread is limited by the conus elasticus. Now, in the anterior commissure area between the two vocal cords, it's midline between the thyroid notch and the inferior border of the thyroid cartilage, with the Broyles ligament that limits the spread of glottic carcinoma. Now, what is the Broyles ligament? It contains the vocal ligament, the conus elasticus, the inner perichondrium of the thyroid cartilage, and the thyroepiglottic ligament. Once this particular Broyles ligament gets breached, early thyroid invasion starts to occur, again changing the staging of the disease. Posterior commissure usually is the area between the vocal processes. And lastly, I want to kind of impress upon the subglottic region, which extends up to the lower border of the cricoid cartilage, with the mobile upper part between the vocal process to the upper part of the cricoid cartilage, and the fixed lower part, which extends up to the inferior part of the cricoid cartilage. Now, this is again the extrinsic and intrinsic muscles. Most of us who have been through Scott Brown know this particular table through and through, so I will not go too much into detail about it, but again, knowing these becomes very important for our resection in cancer therapy. Now, going more core into the depths of carcinomas of the larynx, the etiology here is usually associated with smoking, 70 to 95% with smokers, and this percentage has been shown to reduce in people who become ex-smokers, which is people who quit smoking. And here, specifically in the NCCN guidelines, they talk about classifying our smoker population into subdivisions such as less than equal to 10 pack years, 10 to 20 pack years, and then more than 20 pack years. And then they talk about how these are the subclassified divisions that need to be studied in detail to understand the direct causality and association. Heavy alcohol consumption, there is no role of HPV in laryngeal carcinoma like other head and neck cancers. Advanced age is an etiology, is an association rather, and diet low in green leafy vegetables. There is a diet rich in fats and salt preserved meats. And when we talk about the epidemiology part, 1/3 of all head and neck cases happen to be laryngeal carcinomas with the mean age group of about 65, and males are more predominantly affected by this disease as opposed to females. But the early stage cancers have shown high rates of curability with local control rate ranging between 90 and 95%, something I picked up from the updates of laryngeal cancer epidemiology that came out in the year 2021. And likewise, 80 to 90% for early stage supraglottic cancers. However, locally advanced cancers tend to demonstrate a very poor control rate, anything ranging between 40 and 70%, with T4 and bulky T4 tumor usually requiring absolute laryngectomies. 2% of total cancer burden, or 0.3% of all cancer deaths, happen to have been from laryngeal cancers, and it's the second most common head and neck cancer site, and a diagnosis usually 51% of them are localized, with 15% of them showing distant metastasis, one of the higher numbers in the head and neck cancer arena. The ratio of glottic to supraglottic malignancy is usually 3:1, with India having 2.5% of the global load of cancers, with absolutely strong association with tobacco smoking. Now, when it comes to pathophysiology, the more specific points that I want to highlight in this particular area is that usually, if not always, we find well-differentiated squamous cell carcinomas in these regions. In the glottic, the lymphatic spread is the main, there's about 50 usually at presentation, with 16% showing contralateral involvement of level 2, level 1, and level 2, level 3, and level 4. And subglottis usually shows sparse lymphatic supply. The pathways of spread here, it's something that we have to absolutely understand so that we can trace our tumors the right way. Two major local pathways we talk about is, one is the direct local spread, where we can talk about involvement in the epiglottic region. Again, when the tumor sits there, there is invasion of the vallecula, there's base of tongue invasion, false cords invasion, area epiglottic folds being involved. Again, when we talk about the false cords, usually it's the submucosal spread, with very less amount of them showing exophytic component. When there is area epiglottic fold or arytenoid growths, usually they come in more of an exophytic, cauliflower-like growth things, and then they extend to adjacent sites, more often than not causing fixity of the larynx or the hemilarynx due to involvement of the cricoarytenoid muscles or joint, more than the involvement of the recurrent laryngeal nerve. Along with that, we have to talk about the lymphatic drainage, and I will be dealing with that a little more in detail as we go further. The clinical presentation in supraglottic CA is almost always pain on swallowing, a lump in the throat, some kind of referotalgia, or neck masses. And this is more often because supraglottic has a lot of lymph node metastasis by itself. However, glottic carcinoma is present quite early, with a very early presentation of hoarse voices, right? With a sore throat, or usually referotalgia, or a dull aching earache that comes on. But whenever there is advanced disease, we do see pain in the thyroid cartilage, and also sometimes airway compromise. But late symptoms predominantly hold on to weight loss, with more than 10% weight loss in 6 months, halitosis, dysphagia, and aspiration-like symptoms. Now, going by the NCCN guidelines, there's a very brief outlay of what the NCCN guidelines talk about. Whenever there is laryngeal tumors, mostly T1, T2, with N0, which is clinical nil node, with a few of the selected T3 patients, we talk about conservative laryngeal surgeries. Now, that's where we talk about endoscopic resections with the neck dissection, or open partial supraglottic laryngectomies with neck dissections, or sometimes even definitive radiotherapy if the patients are not very amenable to surgery per se. Then again, we talk about the pathological staging in this particular tumors, where there is node negative masses, which eventually go in for kind of surgical resection of localized areas, and then subsequent follow-ups. Again, whenever there is one positive node without any adverse features, we talk about considering radiotherapy and systemic therapy of all kinds. Whenever there is extranodal extension, and whenever there is positive node, we usually go in with a radiotherapy combined regimens. Now, early stage disease, we would talk about definitive RT or supraglottic partial laryngectomies, and neck is always treated even for T1 carcinomas. And as we go forwards, there is stage 3, which is usually there is attempted larynx preservation surgery with concurrent chemotherapy, radiotherapy. Whenever there is stage 3 with selected stage 4A, we go in for concurrent chemoradiotherapy as treatment of choice, and surgery comes as a second option. And these are the various charts that we follow as far as the NCCN guidelines for larynx malignancies are concerned, with total laryngectomies and neck dissections being the treatment of choice in advanced carcinomas, and select lesions may be treated with concurrent chemoradiotherapy, with total laryngectomy reserved as salvage surgery. Now, just to give a very brief overview of the surgery for supraglottic cancers, we talk about lesions involving the epiglottis or a single arytenoid area epiglottic fold, or the false vocal cords. The structures that are resected in these would be the hyoid bone, the epiglottis, superior half of the thyroid cartilage, epiglottic fold with false cords to the arytenoids, and contraindication would be extension of the tumor to the true vocal cords. Whereas when we talk about supracricoid laryngectomies, there is lesions extending from the supraglottis into one or both the vocal cords with bilateral true and false cords, paraglottic space, pre-epiglottic space, epiglottis, or the thyroid cartilage. And contraindication here would be vocal cord fixity, which is sometimes a relative contraindication with an extension to the cricoid and the thyroid cartilage. Now, total thyroidectomy with or without neck dissection usually is the treatment of choice for advanced lesions, and the removal of hyoid, thyroid, or cricoid cartilage with epiglottis and strap muscles along with the reconstruction of the pharynx would be done, with permanent tracheostomy almost always needed. The speech is reconstituted with prostheses or with electrolarynx. Now, the diagnostic workup. What is the most important thing that we have to understand in the diagnosis? What is the degree of vocal cord mobility? This is a very important aspect when we have to plan the type of surgery that we go in for. Similarly, the number of regions that are involved in the particular tumor that we're looking at, presence or absence of any cervical distant metastatic lesion. Now, this is very important, specifically when we go in for surgeries, to know if there are any second primary tumors that may be concurrently there in the patient. Now, involvement of the base of tongue again becomes important in the surgical resection. Involvement of the paraglottic or the pre-epiglottic spaces are important. Involvement of the thyroid cartilage, any evidence of invasion there, or involvement of the carotid artery and sheath, or invasion into the esophagus, or the soft tissue and adjoining laryngeal muscles, along with the degree of neck node involvement becomes very important. And there is something called the ECOG performance scale that we always rate for our patients to give a brief idea about what is the functionality of the patient at the time of presentation. And then this also comes handy when we talk about the rehabilitation of the patient after the surgical resection and when we are specifically dealing with palliative care patients. Now, what is the most, kind of brief or outlay of what would be the management protocol in a patient that presents to us? There is inspection with direct or indirect laryngoscopy. We pick up, as the image shown there, what would be the clinical findings of the particular patient, following which we talk about the neck nodes, and usually the midline neck node involvement is considered as ipsilateral. Pan endoscopy is done under general anesthesia. That would be the ideal scenario, and the surface and extent of the tumor, vocal cord mobility, along with biopsy of the visible or suspected lesions would be done. And searching for other primary tumors, like I said, with multiple independent primary is something that needs to be worked up with, and imaging in the form of contrast enhanced CT and MRI is done with PET CT to pick up any otherwise clinically occult primary lesions. And pathological classification is the final diagnostic classification that is supposed to be done for a patient, now that we talk about pathological subclassifications as well, but that is done purely on the complete primary resection and then grading of the excised mass. So this is the AGCC classification of the laryngeal tumors. In supraglottic tumors, again, where T1 is when it involves one subsite, T2 is when it involves more than one adjoining subsites or a region outside this, the supraglottis, specifically mucosa of the base of tongue, vallicula, the medial wall of the piriform sinus, without the fixation of the larynx. Now, when we talk about T3, it's always vocal cord fixation and invading into important spaces such as the post-cricoid area, the pre-epiglottic space, paraglottic spaces, and the inner cortex of the thyroid cartilage. Similarly, T4A, T4B is the advanced lesion that I was talking about, where T4A would be the ones that involve the outer cortex of the cartilage, and or involves the tissues beyond the larynx, which is the trachea, the soft tissue of the neck, the deep extrinsic muscles of the tongue, the strap muscles, thyroid, or the esophagus. T4B is very advanced local disease where the tumor is invading into the prevertebral space, encasing the carotid and involving the mediastinal structures. Similarly, when we come to glottic carcinomas, T1A being involvement of one cord, T1B being both cords, T2 is when it starts to extend into the supraglottic and or the subglottic regions with or without impaired mobility of the voice cords. But T3 is always the point where the voice cords become completely fixed with the invasion of the paraglottic space and the inner cortex of the thyroid. And T4A, T4B is similar to the supraglottic classification. Similarly, when we come to the subglottis, that's when the tumor is limited to subglottis in the T1 lesion. T2 is when it extends to the vocal cords with or without impaired vocal cord mobility. T3 is when the vocal cord fixation comes in with paraglottic space and cortex of thyroid involvement with T4A, T4B being the involvement. Classification is the one that is done in a form where N1 being ipsilateral single node 3 centimeters or greater in dimension without extranodal extension. Now, this is something that was very specifically laid, focus upon when it came to the AJCC classification of the 8th edition of the AJCC. And N2A, N2B, and N2C was predominantly anything that ranged between 3 and 6 centimeters with extranodal extension noted in N2A and N2B being the ones which is between 3 and 6 with multiple ipsilateral nodes, and N2C was bilateral or contralateral lymph nodes, none of which crossed 6 centimeters, and N3 would be the ones which is more than 6 centimeters, again subclassified into N3A and N3B. And the clinical stage N is the one that we follow when we stage our patients as soon as they present to us in the clinical workup, where N1 is again less than 3 centimeters, N2 A, B, and C would be 3 to 6, and then the different variants of that, and then N3 A and B with more than 6 centimeters with or without extranodal extension subclassification. And here we talk about the histological grading and the AJCC prognostic stage, the AJCC prognostic stage groups, where we talk about when the T1, the NNM, what would be the stage of the disease, and then that's how the staging is classified. Along with that, there is the histological grading with well-differentiated being G1, moderately differentiated G2, and G3 would be poorly differentiated with metastasis being M0, MX, or M1, depending on whether it is no metastasis or occult metastasis or defined metastasis. Now, this is the AJCC staging manual, which talked about the different illustrations of T1, T2, T3. These are beautifully described in the document, where they talk about the different lesions of exactly how they would look and what would be the involvement and exactly how a T1, T2, T3 and T4 advanced diseases would look like in the different cross sections of the laryngeal framework. Now, going forward into the management protocol, brief overview exactly how it works. We talk about the clinical, the diagnostic workup, where the different imaging and all the endoscopies are done, following which we make a brief treatment plan of whether surgery, chemoradiation, or palliative care is planned for the patient. And then we talk about rehabilitation in the form of speech or swallow rehabilitation, along with nutrition being an important part of how we go about managing our patients with these disorders. A special mention has to be done when we talk about early glottic cancers, part of the laryngeal malignancies that we see on a day-to-day basis. Transoral laser microsurgery. Now, this is something that is done for T1N0 lesion, where the tumor is first divided with the laser to assess the depth of invasion, and the deep margins of the tumor is followed using the laser, applying tension over the specimen. Same way when we come to T2N0, the epiglottis is first divided vertically, and then the tumor is split the tumor is vertically split to assess the depth of invasion, and the left supraglottis is removed first with the arytenoid being spared. The transoral robotic surgery is something that's being spoken about very frequently. So that's something that I want to just throw a brief light on. The advantages when it comes to transoral robotics is that there is computerized mechanization of the robo, allowing the surgeons deeper access and dissection of anatomical sites and better access to various lesions with no external incisions to the patient's neck, and the potential absence and decreased incidence of tracheostomy in these patients has shown to be of advantage, with more rapid swallowing rehabilitation and decreased blood loss with a shorter recovery period. Again, open partial laryngectomy highly effective in primary treatment of early stage glottic tumors with relatively poor functional outcomes. You can talk about the cordectomies, the vertical hemilaryngectomies, and the different kinds of cordectomies that we talk about is type 1, 2, 3, 4, where there is resection of the vocal folds with the epithelium being type 1, the resection of epithelium with rinky space, and the vocal ligament being type 2, the resection of vocal fold through the vocalis muscle being type 3, and extending from the vocal process to the anterior commissure being type 4. And again, type 5A is when it includes the contralateral vocal folds. These images clearly show exactly how these cordectomies go, with 5B being resection including the arytenoids, 5C being the ones including the subglottis, and resection including the ventricle and false chords being 5. So the 6 is the resection of anterior commissure with bilateral anterior cordectomy, which may include the subglottic mucosa and the cricothyroid membrane. The open partial laryngectomies, whenever there is anterolateral type of hemilaryngectomies, the glottic tumors are the ones where there is no involvement of the anterior commissure, but the thyroid cartilage is exposed, perichondrium is elevated, with midline laryngofissure, which is performed. And again, whenever we talk about the frontolateral hemilaryngectomy for these cases, this is preferred if the tumor involves the vocal cords on ipsilateral side, with the anterior commissure up to 1/3 of the contralateral vocal cord, and the vertical cartilage cuts in the thyroid is performed 1 centimeter paramedian from the anterior midline on the contralateral thyroid ala. Lastly, the anterior vertical laryngectomies is a preferred method when there is anterior commissure tumor that involves not more than anterior third of one or both the vocal cords, with a successful functional outcome that can be gained with the conservative laryngectomy, conservative laryngeal surgeries that we talk about here. Radiation therapy for early tumors, again, the target volume depends on the primary tumor itself. The original lymph nodes are not treated due to low risk of lymph node metastasis. Usually there is 2 lateral fields with the laryngeal skeleton from the thyroid notch and superiorly to the inferior border of the cricoid cartilage, with a dose of about 50 to 55 gray in 16 to 20 doses over 3 to 4 weeks. And as such, the management of early glottic cancers can be subdivided. This is a very brief overview of exactly how the management protocol of it goes. And then I would like to now focus on the total laryngectomy part, something that we've been seeing a lot more commonly in our center in the recent past. And what are the indications here? There is advanced laryngeal malignancies with extensive cartilage destruction and extralaryngeal spread, involvement of posterior commissure of both the arytenoids with cricoarytenoids, circumferential submucosal disease with or without vocal fold paralysis, subglottic extension to involve the cricoid cartilage, hypopharyngeal tumors from the postcricoid spreading, the massive neck metastasis or thyroid tumors, or whenever there is signs of severe aspiration following partial or near total laryngectomy, and extensive pharyngeal or tongue-based resections that may be required. The different incisions that are used are the Gluck's-Sorensen incision, where there is U-shaped, where 3 corners are avoided, gives a good exposure. The pharyngeal closure line is entirely within the apron flap. Subplatysmal flap is raised, so the vascularity of the flap gets preserved. The stoma is incorporated into the incision, so that helps. And the vertical limb is medial to the sternocleidomastoid. The horizontal encircles the tracheostomy, and the highest points are usually the mastoid process, where the neck dissection is done in the same incision. So steps of laryngectomy, just to go over a brief overview before I jump into showing you cases of what we do here at Bangalore Head Neck Sciences. Subplatysmal flap is initially raised with the strap muscles, which are retracted. The total or hemithyroidectomy can be done based on the tumor and whether there is requirement on case-to-case basis. There is release of the larynx from the tongue base superiorly, the pharynx posteriorly, and the trachea inferiorly. Suprahyoid is initially released, the omohyoid dissected and divided. The pharynx with the paralaryngeal paratracheal space from the cricoid sheath and the constrictor muscles are removed. And then posteriorly, posteriorly, the tissue is dissected Now, the anterior rotation of the posterior part of the thyroid is done with release of epiglottis from the pharynx. There is the cricoid with or without the upper tracheal release and resection that is done with the pull-up of the trachea and end tracheostomy. Now, this is a good set of images that show the different steps of laryngectomy. And finally, there is stoma creation, which is done with a nice tracheal pull-up and the tracheoesophageal puncture that is planned. If it's primary, then it's done in the same sitting, otherwise as a secondary. And then there is closure to create the neopharynx in 3 layers, which is again going to be in the T and the vertical and the horizontal. Neck dissection in the supraglottic cancer perspective is always the highest incidence being the nodal metastasis. Here I've given a brief overview of the statistics that I found for 2022, with T1 having about 10%, T2 having 29%, and T4 going up to 57% clinical occurrence, where the levels involved are usually the 2, 3, and 4, 1 to 5 only when there are other nodes involved, with bilateral metastasis that were more common in bilateral or midline supraglottic diseases. Whenever there is dissection that is planned, if it's N0 or N1, we talk about bilateral selective neck dissection, or if it's N2 and N3, then we take a call on selective or a modified radical between MRND 1 to 5. With the glottic carcinoma, the overall incidence is quite low, with 5.9% clinical occurrence of nodal metastasis and bilateral metastasis being quite rare, and the levels being level 2, 3, 4, and 6. Now, in subglottic carcinoma, though, the primaries are rare, and hence the incidence of nodal mets need for neck dissection falls between 4 and 27%, with level 6 being most common, and the mediastinal metastasis of 46% is seen, along with distant metastasis. Now, the technique here is, again, selective neck dissection. When we talk about, there's incision, which is the hockey stick incision that is extended bilaterally, or when it's MRND, then the different incisions, of course, we extend from the same Gluxor incision. And again, now I'd like to get into the details and specifics of the case studies and how we go about doing our total laryngectomies. This was a patient that came to us, about 65-year-old male, who had come in with hoarseness of voice, long-standing. The patient was quite insistent not to undergo surgery, and the patient was eventually worked up, and we found that the patient had a T4 dissection as being shown. Just give me 1 minute. And the upper flap is always sutured about 2 centimeters above the level of the hyoid, and the lower flap is sutured down at the level of the sternal notch. And following which, after a good subplatysmal flap excision, because flap exposure, because it gives a good vascularity, it retains the vascularity of the flap. There is traction that is done on the flap so that the field stays predominantly bloodless, and then suturing the flap down to the drapes really helps give us a good exposure during surgery. And following that, we transect the omohyoid, which is crosses the internal jugular vein, and then the sternocleidomastoid, the medial edge of the sternocleidomastoid is defined. Again, it's retracted in this image, and the paracarotid tunnel area is entered. Here again, we can visualize clearly the region of the under the sternocleidomastoid, and as soon as we delineate the paracarotid tunnel space, we dissect it down. Then we cut down the strap muscle. We dissect down the sternothyroid and the sternohyoid muscles, and then after we have dissected away the thyroid region, we remove the middle thyroid vein secured, and then eventually the entire mass is slowly dissected out, and the soft tissues are all removed. Here you can visualize the thyroid muscle being cut and resected away. That is the upper end of the epiglottis being held on, and that's when we had completely dissected out the epiglottis region, and as we can see, all the structures very clearly visualized here. again, after the area is being exposed, that's when we're able to see the pharyngotomy areas, and then the dissection is further carried out, and the pharynx region is exposed, and after securing the area in the midline, as can be seen in the center, we close it down with the midline sutures, and then 3-layered closure of the wound is done. The first layer being the T-shaped, and then vertical and horizontal, as I'd shown before, and this was the complete specimen being dissected out. This was another interesting case that had come to us, 65-year-old female who had come from Africa, who was being recurrently misdiagnosed with hoarseness of voice, being in the lines of chronic laryngitis, and she was a physician by occupation, and was quite distressed when we were able to put it down to laryngeal malignancy. Again, these are the same steps that were followed in the previous surgery, where we resected, where we elevated a subplatysmal flap, and then we exposed the subplatysmal flap region, maintaining the vascularity of that area. Again, the IJV is being dissected after exposure and dissection of the strap muscles, and then subsequently, the sternothyroid, sternohyoid muscles, and the constrictor muscles are all divided, as you can see in this image. And then the entire tumor mass is being dissected away. And as we can see, the posterior extent of the particular tissue block is being tractioned away, and all the layers of the dissections are in the lines of the resection is done in a stepwise fashion, where now the epiglottis is being tractioned forwards, and pharyngotomy is done, and exposure of the pharynx is seen in the midline, and subsequently the entire tissue mass is being removed, and that was when we put an incision right in the midline to be able to visualize that the tumor mass had crossed the midline of the particular area. Now, when it comes to the radiotherapy part of the treatment, carcinoma in situ, usually the treatment guidelines say external beam radiotherapy for them. T1, T2, there's usually external beam radiotherapy alone, or surgery that is reserved for salvage after the radiotherapy failure. When it comes to favorable T3 or any N, there's radical external beam radiotherapy with concurrent chemotherapy. And whenever there is unfavorable T3, T4, we talk about total laryngectomy with ipsilateral or bilateral neck dissection with postoperative radiotherapy. In the NCCN guidelines part of the radiotherapy, there is carcinoma in situ with endoscopic resection or radiotherapy that is preferred. If it is amenable to larynx preservation surgery, then the radiotherapy with partial laryngectomy or endoscopic and open resection is done as indicated. If there is no adverse features with extranodal extension or positive margins or any risk factors, then systemic radiotherapy is given and is feasible. But when it comes to T3 requiring total laryngectomy, they prefer the concurrent systemic therapy with radiotherapy. And with the surgery, whenever there is N0, there is laryngectomy with ipsilateral thyroidectomy, and N1, there is laryngectomy with ipsilateral thyroidectomy as indicated, or bilateral neck dissection, or pretracheal and ipsilateral paratracheal lymph node dissections. If there are adverse features associated, then we always talk about the systemic therapy or radiotherapy, and the neck treatment has to be included here. If it is T4A, again, when with the surgery, N0, N1, N2, or 3, total laryngectomy with or without thyroidectomy, depending on the, with thyroidectomy in T4A, with ipsilateral or bilateral neck dissection, and pretracheal and ipsilateral paratracheal lymph node dissections. If there is no adverse features, then we go ahead and follow up the patient. But if adverse features are involved, again, we go in for concurrent radiotherapy. Now, what would be the take-home message in this particular webinar? We talk about early identification of the disease whenever there is high-risk factors, and clinical picture that looks very close to an advanced or an early laryngeal involvement, always a good idea to work up diagnostically the patient with a systemic treatment protocol. Thorough disease clearance with good skillful dissection and good skillful clearance of the disease becomes important. And again, rehabilitation using things like tracheoesophageal processes or electrolarynx becomes important. And these are where we can find us, the website and the email link. Any questions or queries of any kind based on this webinar, or if there is any ideas on what else you'd like us to cover in the future webinar topics, please do let us know. And these are our handles as well, and you can reach out to us, and we'll try our best to get back to each of you personally. Thank you for listening.